as Dr. Seagraves knows, I monitor from pre-pregnancy through the first year postpartum. And what we have found, well, in terms of my personal story, when I told you I had preeclampsia post-delivery, was actually caught before I delivered, but I still was able to deliver my baby at home because my midwife knew my baseline. So my blood pressure at baseline is 100/60. Because she delivered my first baby, she knew that of me. She also knows about the way I eat, exercise, so all the things that someone should know about you as your provider. But when my blood pressure got to 128/78, she was concerned. And the doctor who saw me after delivery, when he saw my blood pressure, he was like, well, she's Black. She lives in the South her whole life. She's old. I was 36 when I had my, 35 when I had my child. She's old. She probably never had a primary care doctor in the first place. Her kidneys are not going to recover. I've seen people like her before. It's just a lot of assumptions. And so his assumptions combined with the protocol numbers, the guidelines, would have had him miss my preeclampsia, where because my midwife looked at me as an individual, she was able to catch it. And so from that experience, I started thinking, well, what if she was monitoring other things other than my blood pressure? And so that's when I decided to send women watches and monitor things like their oxygen saturation, resting heart rate. We do monitor their blood pressure. We also do their blood glucose if they are at risk for gestational diabetes. And the interesting thing is, even though there are guidelines that say whether someone is at risk for gestational diabetes or not, but the reality is that most women don't know their hemoglobin A1C, so they don't know if they're at risk or not. And because the body, the placenta actually releases a hormone that allows blood sugar to stay around in the bloodstream, sugar to stay around in the bloodstream so that the baby has more access to it. Women are just at increased risk for gestational diabetes because of what happens physiologically. If you have more sugar floating around in the bloodstream, that means the pancreas has to release more insulin. And if it's not ready to meet that demand, then you can be at risk too. And so when it says, when there are these lists of, what makes you more at risk, I think it's important too to look physiologically at what puts them at risk as well. But also monitoring things like sleep quality and how they change. And so about halfway through one of our mom's pregnancies, she was about 20 weeks, they say that you can pick up on preeclampsia, but she was on our monitor for maybe 2 weeks, okay? And at that second week, believe it or not, her heart rate went down. Her stress as measured on the watch by HRV. So it's like having a telemetry monitor at home 24/7. So that's what HRV kind of does. And so her stress actually went down as well. And something called her body battery, which is the amount of energy or gas in your body's tank, it actually went up. So during pregnancy, we actually expect the exact opposite. We expect that people's resting heart rates will go up, their stress will probably go up some, and they may have a little bit of a harder time recovering. Not drastic if they were in good shape before, but if not, then you see a drastic difference. Well, with this particular lady, things started improving and we called her immediately. And so sometimes in the hospital system, you're looking for things to get worse. But if things get drastically better, that can tell you something as well. So for her, picked up the phone and called her. Her blood pressure at that time was about 120/70 something, but her baseline was 90/50. And I told her, get to the hospital immediately. And she said, well, I've been in contact with my OB's nurse and they said everything's fine. I can just wait until Friday. And, so I just explained to her, your blood pressure is different than your baseline. By the time she got to the hospital, her blood pressure was 140/93. And that was only 2 hours after I talked to her. So what we have to really understand is there are guidelines, but she had never hit the guideline upper parameter for intervention, and neither did I, and neither do a lot of other people. But what we have to look at is what other things can we see? So for her, I asked her, how much are you using the bathroom? And she said, back to back. It's almost like I sit down and then I have to sit down again. I even had to stop going to work because I was going to the bathroom so much. That's a sign that her body, if protein, so one of the signs of someone having preeclampsia, so they have protein in their urine. And when some of the unseen signs, so no one is necessarily going around checking protein all day, right? Is that if you use the bathroom and it looks like foam, so the urine looks foamy, that's a sign that there is protein in the urine. So when I asked her, does your protein look foamy? She was like, yeah, it looks pretty bad. It looks pretty different than what it looks like before. And her swelling had gotten drastically worse. And so sometimes it's that we see those signs or ask for those things that other people may not necessarily be paying attention to. And so that's how we have been able to catch things like that. And then heart failure, I just want to bring this one up, Dr. C. Grace, and I'll give it back to you. We had a mom who was sent home, and one of the things that I love to check in the hospital, if I were in the hospital, I would check that I check with these moms now that we're connected, is their hemoglobin. So what was it before you got pregnant? What was it at 12 weeks when they check it? They check it at 12 and 28 weeks typically, but then they don't check it again until after the mom delivers. And so, unless she's going to have a C-section, then they check the numbers again. But for our mom, they don't have those numbers. Right. And so when we're looking at oxygen saturation, it's great because if someone doesn't have the hemoglobin stores, then they're not going to be able to create the oxygen that's needed. Or if they don't have the iron because the baby is taking it that third trimester and making its own hemoglobin, then their oxygen saturation will come down on our end and their resting heart rate will go up. Because what we know about the body is that if the oxygen demand is not being met, the heart rate's going to go up because it's like you're trying to use what you have and deliver it to all the muscles needed. So that process has to be done faster if enough oxygen is not readily available. So for this particular mom, her hemoglobin went from 12 to 8. So if you've worked in a hospital system, you understand at 8, nobody's giving you a blood transfusion. Nobody's doing anything. They're looking at that like, oh, she's just on the lower side. She just had a baby. Well, for this particular mom, her resting heart rate stayed up at about 120. So we know we're looking at 60 to 100 as normal, but during pregnancy, the resting heart rate will go up a little bit. So if a mom starts at 60 on our system, typically she'll get to like 75. If she starts at 80, she'll typically get to about 95. You should not be resting at 120 into your heart rate. So this is what her resting heart rate was. Nobody went in to see her in the hospital. I told her, you should really stay. I know that you're at 8, but something's not right. She was ready to go home. Doctors were ready to discharge her. So she left. The next day, resting heart rate kept going up. And so by that second day, I called her husband and I was like, look, she's not going to be happy with you, but she needs to go home. I cannot watch this on the dashboard and know that women are going into heart failure and having to be readmitted that first week or dying within that first week because this stuff is missed. So he took her to a med stop. They did an EKG. They immediately sent her to the hospital. They did an echo. Cardiologist was brought on board. She was given a beta blocker to help with her heart rate. He said that there was fluid around her lungs and that she had 3 weeks. He would have given her 3 weeks before her heart was completely taken over and failed. And so some of those numbers that we're supposed to be looking for when we're at the hospital, so the hemoglobin, change in hemoglobin, not what is it now, but what was it pre-delivery? What was it 10 years ago, right? We need to know what was her baseline, what is it now? BNP, so that number, that lab number can let you know if someone is in heart failure. So we're typically as PTs and OTs looking to see, well, is it under 100? But really, like, it really shouldn't be, like, you shouldn't have that. That number is not supposed to be high. But what they're finding is for women who have had the peripartum cardiomyopathy, those numbers are about 5 times that. So if we can just start checking BNP levels, and if they're not checked, then asking for them, because some women it's being misdiagnosed. We just had a mom about a week ago. Her heart rate was up, her oxygen saturation was down, but she delivered her baby 3 months ago, I believe. And her doctor told her that she had asthma. They're like, you just have asthma. And so she was put on asthma medication, and her data just kept looking worse and worse. And so the idea is that, well, if you're put on a medication, then your data should probably start looking better. But she wasn't feeling better. She was still short of breath with everything. But one thing to know about her past medical history is that she was on bed rest for 55 days before she delivered. And so when you think about it now, she's 55 days. She delivered her baby. The baby stayed in the NICU. So now she's back and forth between home and the baby, just doing a lot. You were just on bed rest for 55 days, and now you're expected to get up and run a normal life because you're going between the hospital that's 45 minutes away from your home. And so she is now they did send her to a pulmonologist, but the new recommendation is a cardiologist. So I told her, just ask your doctor. It doesn't harm, it doesn't hurt to rule out heart failure. So get these labs drawn, go see a cardiologist. And that's what she's doing now. So we'll see what happens, but with the asthma medication, that didn't help. So at the end of the day, we need to make sure that if something's not helping, we do something else so that they don't have a bad outcome that could have been prevented.
So just to understand, if I'm going back to this slide and I'm looking at these parameters, and Jackie just asked this question, if we're not necessarily going off of this chart, even though this is what our hospital uses, Dr. Sylvester, to determine if someone is safe to go home, as a therapist, if I have data from when that person first came in and their heart rate was 75, 80 resting, and now they are at 130, 135, or excuse me, or 115, 120, and their team doesn't seem to be alarmed at that. What can I say as an acute care therapist to say, this is actually alarming to me? Can we look at BNP, or can we look at something else and look at more information with just what I have in the hospital? What's the one thing that you would recommend that we say?
I would say exactly what you said. And then to be honest with you, and I know everyone is not going to take my approach, but sometimes I contact the other provider directly. So in a hospital, even when I was in the hospital, this is what I did. If the team that was on board was not looking, then I would say, okay, who would be most interested in knowing that this is happening? Because they can probably talk to the doctor for me. So I've had to do that for neurology. I've had to do it for cardiology. I had to do it for nephrology. And so if I felt like these numbers are alarming, then I would just contact the doctor that I thought could help. And what they would typically say is, oh yeah, I'll talk to such and such, Dr. such and such, and just ask for a consult, because they, like us, can't just be brought on board because they want to be, they have to be referred to. And so that is my workaround. And it has been my workaround since I worked in the hospital. And now since I do too, like you, go in and see women a couple days after, I'm constantly connected with them because of the watch. If I'm in their home, but they don't have a watch and they have these symptoms, I tell them, why don't we call your doctor, your primary care doctor, not your OBGYN. Why don't we call your primary care doctor, tell them what's going on, and see if we can get a cardiologist on board. And normally they're like, okay, their general practitioner says, okay. And so I try to arm the women with the power as well. So it may not be that the team that is currently watching them is as concerned, but you can let the women know who they need to follow up with afterwards.
So an OT and PT in the hospital probably has more power, obviously, than probably anyone else, right? Anyone who's practicing the home and anyone practicing in the outpatient. Yes. I have you on record saying that because, yes. Yeah, because they could actually go above the OB and talk to the cardiologist on another floor and say, listen, I'm looking at some values. I'm concerned. Would you mind talking to Dr. So-and-so?
Yes. And I'm telling you, it has happened. I know that we're talking about maternal health care, but there was a lady who had a hip fracture. She was 21. She seemed like she was fine. And so PTs were just giving her a walker, helping her get back to walking. She was non-weight bearing. But then all of a sudden, she started having difficulty speaking, swallowing, left-sided weakness. And so we're all thinking she's having a stroke, right? Well, her primary doctor had already decided she was going home. There were no more labs were going to be done. No more images were going to be taken. And so I contacted the stroke coordinator. We are a level 1 trauma center, stroke certified, total joint, replacement center. And so if we're stroke certified, we need to be looking into the things that we tell people at home to look for if your loved one is having a stroke. And so the stroke coordinator overrode the doctor, got the images done. They caught the bleed, because I think she ended up having a bleed. And then she was sent to acute rehab instead of being sent home with home health. So in the hospital system, we have a lot of power because we can, like you said, communicate directly with the doctor. And the beauty is there are a lot of those kind of doctors there. So it's not like you just go to one. There were several neurologists that worked at my hospital. And so if one said no, I just went to the next one and was like, look, this is what's going on. Do you mind talking to Dr. such and such? Mm-hmm. Because at the end of the day, even if nothing is wrong, at least we've had it looked into.
I agree. Okay. Thank you so